everyone. I'm just going to be doing a quick talk through video for my chart on how I organize the information on the congenital heart defects. And so one of the first things that you'll notice about my chart is that I did not include the things that we would be doing as nurses as far as our assessment or potential interventions for patients with these conditions. So I will be verbally explaining that since it's not here on the chart. And so just a couple of quick things I want to mention before we get started with explaining my chart is if you are a little bit rusty with your anatomy of the heart and the way that blood is normally supposed to flow, just kind of take a quick minute and brush up on that information, just like quick 5-10 minutes in your notes, watching a video, because having that solid understanding will really help you to understand what's going on with these defects. The other thing is if you have not taken maternity or if the anatomy of the fetal heart is a little bit rusty, once again, just like take that 5 to 10 minutes to brush up on it or watch a quick video about some of the normal openings in the fetal heart, because those are also going to be playing a role in these conditions as we go through and explain. The last thing I want to mention is that you don't have to make your chart look exactly like mine. You just need to make it in a way that makes sense to you, and this video is intended to help you and just getting started and organizing the information. So the first thing that we are going to start with is over here on the left side of the screen, the defects that affect pulmonary blood flow. So when we're talking about pulmonary blood flow, we are talking about the flow to the lungs. And so I organized mine into 3 sections. I've color coordinated them. So we have our red section all the way to the left, which is our increase in pulmonary blood flow. We have our middle one here in purple, which is mixed blood flow, and then we have our decrease in pulmonary blood flow. And so I color coordinated these based on the oxygenation of the blood. So red represents our oxygenated blood, blue is our deoxygenated blood, and then purple, of course, is a mix of the 2 colors representing the mixed blood flow. So first I will go ahead and get started with explaining all the way to the left here, which is our increase in pulmonary blood flow. And you'll notice that in all 4 sections here, I have a note that says left to right shunting of blood, left to right. We see that over and over. And so that is sort of speaking to how we get to the fact that these conditions have an increase in pulmonary blood flow, because what's happening is that blood is coming from the systemic circulation to the right side of the heart. It is going to the lungs and getting oxygenated like it's supposed to. That's why we have this color in red. It's getting back delivered to the left side of the heart like it's supposed to. But after we get to that left side of the heart, that's where things, for one reason or another, are going wrong. And instead of going out into the systemic circulation, that blood is making its way back over to the right side of the heart and shunting over. And when that blood is redirected, then when we get to the right side of the heart, then we just go right back to the lungs. And so that's why these conditions have the increase in pulmonary blood flow. So if you can get a solid understanding of that, you're going to be really solid on these defects over here. And so we're going to start all the way to the left over here with our ventricular septal defect. So we'll break down that title really quick, just ventricular septal. And so that's telling us that there's a problem with the septum between the left and right ventricles. And so the problem that we're having is that there's an abnormal opening there. And so with that abnormal opening, that blood is going to flow from the left side of the heart, the left ventricle, over to the right ventricle, and then that blood's going to go back into the lungs. We have something similar over here on our next one, which is our atrial septal defect. So breaking down this word, atrial septal, we know that there's a problem with the septum between the left and right atria. And once again, we have an abnormal opening, which is allowing that blood that gets delivered to the left side of the heart to once again be shunted and make its way back to the right side of the heart, where it's going to once again go through that pulmonary circuit, going back to the lungs. So once again, we're dealing with that oxygenated blood that just keeps looping back around to the lungs. And over here we have our patent ductus arteriosus. So this is kind of what I was talking about when I was talking about being familiar with the anatomy of the fetal heart. So a ductus arteriosus is a normal opening for the fetal heart, and it allows an opening from the pulmonary artery directly to the aorta. And what it does is it allows bypassing of the lungs when baby's still in utero because baby's not using their lungs yet. But about 24 hours after the baby's born, this opening should close. And so when we have patent ductus arteriosus, what happens is that opening is not closing like it's supposed to. It's staying open. So what's happening is that our oxygenated blood is going through the circuit like it's supposed to. It gets all the way to the left side of the heart, but when it goes to go through the aorta for our systemic circulation, what's happening is that some of that blood is going back through the pulmonary artery. So instead of going to the right side of the heart and then going to the lungs, it's just going through the pulmonary artery directly to the lungs. And so that's how we get that increase in pulmonary blood flow with this one. And so one of the big things to know about this one is that there is a medication, I've listed it down here in red, indomethacin. So this is the medication that is used to actually close that opening of the patent ductus arteriosus. So this is a non-surgical way to treat it and just get it to close up like it should. So moving on to our fourth one over here, we have our atrioventricular canal defect. And so with this one, what we should usually have is two separate atrioventricular valves. One is on the right side, one's on the left side. What happens with this one is that there's sort of just one big one, and it allows blood to flow sort of and communicate with all four chambers of the heart rather than just one side at a time. And so because we have that extra access, once again, we are going to have blood that is moving from the left side of the heart over to the right side of the heart. So some things to keep in mind specifically for our conditions with increase in pulmonary blood flow is that these are creating extra openings and extra access where there shouldn't be, and that's where the blood is flowing through. So it's going to be expected, as you see it listed here, that these kiddos are going to have murmurs. And these murmurs are going to be persistent beyond what you would typically expect for a newborn. Because when babies are first born, you will expect some murmurs, but they should go away as openings are closing. But if they're persisting, then that tells us that something is wrong. And so also, when we're talking about the increase in pulmonary blood flow, you have to start thinking about, okay, well, what does that mean as far as our heart failure is going? So we know that there's a difference between right and left-sided heart failure. So think about what side of the heart is failing to get blood to the system that it should be getting to, and what are the things associated with that side of heart failure. So don't want to tell you guys out of the gate, but just think about that and what you would expect on your assessment and things, potential complications to look out for. The other thing I just want to quickly mention, since we are talking about our assessment for kiddos with heart defects, is that with pretty much all of them, especially if these kids are hospitalized, you're going to be doing a full assessment. So I'll just take a quick pause to go over that. And so with our cardiac assessment, we're going to have our vital signs with our blood pressure and our heart rate, and our O2 saturation. And so especially with O2 saturation, that might play a bigger role depending on the defect. You're going to be auscultating your heart and lung sounds, palpating the pulses, capillary refill, and assessing the skin color of the patient. Especially for newborns, you're going to be looking at the lips for cyanosis. And so those are just some things to keep in mind just overall for your assessment, but also to know which ones are going to be sticking out more. So the ones over here on this left side, what's going to stick out more so is going to be that murmur that you would actually expect to hear. So before we go to mixed blood flow, we're going to be talking about our blue section here, which is our decrease in pulmonary blood flow. So I think that just talking about increase versus decrease, it'll help it make sense more for our mixed blood flow. So our first one over here is tetralogy of Fallot. So when we break down this word tetra, that means 4. So we know that there's going to be 4 abnormalities that are coming together in this condition. So the first one that we have here is our ventricular septal defect. So we just talked about that. We know what that is now. That's our abnormal opening between the left and right ventricles. Number 2 here we have an overriding aorta. So what that means is that the aorta is not in its usual placement in the heart. Instead, with this condition, the aorta is actually sort of placed near where that ventricular septal defect is. And so as you have your blood that is shunting from left to right, that opening that's near that, the aorta that's near that opening is also going to have access to that deoxygenated blood on the right side of the heart. Third, we have pulmonic stenosis. So this refers to narrowing of the pulmonary artery. And so we'll explain that in a little bit more detail at the end when we get all the way to the right over here for pulmonic stenosis. But when we have narrowing of a vessel, we know that blood is going to have a more difficult time reaching what's at the end of that vessel, which in this case is the lungs. So we're having a harder time getting the blood to the lungs to get oxygenated. And then fourth here we have right ventricular hypertrophy, which is sort of to be expected because we know that the blood that is going through that narrowed pulmonary artery is coming from this right ventricle. And so if this right ventricle is having to work harder to pump the blood through that narrowed vessel, of course it's going to hypertrophy. So to just take a quick minute to connect the dots here, what we basically have if we instead start at number 3 is that we have a narrowed vessel getting to the lungs to get blood oxygenated, okay? And so then our right side of our heart is working harder to pump that blood through that narrowed vessel. So we finally get our blood through to the lungs. It makes its way to the left side of the heart, but then we have this ventricular septal defect that is taking that oxygenated blood and shunting it back over to the right side of the heart. So we're not as effectively going to be getting that oxygenated blood out to the rest of the body because of that flow from the left side of the heart to the right side of the heart. So as we have this flow, we also have the overriding aorta, which is going to catch some of that oxygenated blood, but once again, it's going to have access to that deoxygenated blood from the right side of the heart. And then also the thing to keep in mind with right ventricular hypertrophy is that as the muscle hypertrophies, the actual room that's left in that ventricle for filling with blood is going to be smaller. So we just have all sorts of things going wrong that are contributing to difficulty with oxygenating the blood to start and then getting that oxygenated blood out to the body. So that's why this one is considered to be a cyanotic defect, because it's so difficult to get that delivery of oxygenated blood to the body. And so the big thing that you want to keep in mind with this is that these kids are going to have what's called TET spells. And during those spells, one of the things that's really helpful is this knee to chest positioning. Oh, please forgive me, I misspelled position. But that knee to chest position is going to help them with increasing blood flow to the lungs, which is going to help with their oxygenation. So that's a really big one that you want to keep in mind. And going back to the things in our cardiac assessment, assessing the O2 saturation for these kiddos is going to be really important because this is a cyanotic condition, and so we really want to keep an eye on how low that O2 sat may be dropping. And then of course we're going to be keeping a look at their skin color. We want to check their capillary refill to assess how their systemic circulation is doing, especially if you are recognizing that they're having a TET spell. So moving on over here to tricuspid arteria. So tricuspid, this is referring to the valve, the atrioventricular valve on the right side of the heart. And so what's basically happening here is that there is not a tricuspid valve. So we don't have any communication between the right atrium and the right ventricle. So that's pretty bad, right? Because then how's the blood ever going to get oxygenated? How's it ever going to get out to the rest of the body? So once again, this is where those openings in the fetal heart or even an abnormal opening come into play to give these kids a fighting chance. And so what we have here is that blood is still able to flow through an atrial septal defect or a patent foramen ovale. So the foramen ovale, if you guys are not familiar with this one, is a normal opening between the right and left atrium, and that allows blood flow in the fetal heart. And that is normal, but it does close after birth. And so for something like this, we would actually want to be hearing a murmur. We want to hear that blood flow because that tells us that blood is able to move from that right atrium. And so in this case, a murmur is actually sort of a good thing, right? Once again, because this is a cyanotic condition, we want to be keeping an eye on the O2 sat, our capillary refill, and our skin color. And just a quick note, as far as interventions would go, we know that if our O2 sat is dropping, that we are going to want to intervene by providing oxygen, but also keeping in mind the age of the child and noting that the O2 sat for a newborn is not necessarily going to need to be as high as it would for an adult. So just keep that in mind. Our middle one here is our mixed blood flow. And so with our mixed blood flow, we have transposition of the great arteries. So in breaking down what the title of this one is, the great arteries that is referring to are the aorta and the pulmonary artery. So in a normal heart, we have the pulmonary artery leaving the right ventricle and going to the lungs and being oxygenated. Blood is getting oxygenated, then it gets to the left side of the heart, makes its way down to the left ventricle, and then we have the aorta, which is leaving the left ventricle. So in transposition of the great arteries, these arteries are swapped. So instead what we have is our aorta is leaving the right ventricle, and the pulmonary artery is leaving the left ventricle. So rather than having everything connected where the right side of the heart leads into our pulmonary circuit, and then we get to the left side of the heart and we get a systemic circuit where everything's connected and going well, instead what we end up with is this sort of like closed loop systems. So we have a closed loop for our pulmonary circuit and we have a closed loop for our systemic circulation. So our pulmonary circuit, where blood goes to the lungs, what's happening is that the blood is getting to the left ventricle. It's going through the pulmonary artery, going to the lungs and getting oxygenated, and then it's coming back through the pulmonary vein and being delivered to the left atrium. And then we have our closed loop systemic circulation, which is blood is being delivered to the right atrium, it's getting to the right ventricle, but then it goes through the aorta for systemic circulation without ever having gotten to the lungs, without ever having a chance for that blood to get oxygenated. And it's going through the systemic circulation and then once again being delivered to the right side of the heart where there's never any oxygenation happening. So once again, this is another condition where those openings in the heart are going to play a big role in giving these kids the fighting chance. So what we have here is that our patent foramen ovale or a patent ductus arteriosus allow mixing of that oxygenated and deoxygenated blood. So those openings are what allows for a little bit of that oxygenation to get into that systemic circulation to help with getting these kids some oxygen in the rest of their body. And so a big one for this one is the treatment for this is prostaglandin E. So this is not going to cure anything, but the big thing about this one is that it is going to keep those openings like the foramen ovale or the patent ductus arteriosus. It's going to keep those open up until the point where these babies can have surgery for the arterial switch operation. And the arterial switch operation is exactly what it sounds like. So it's basically taking those great arteries of the aorta and pulmonary artery and putting them where they are supposed to be so that now we don't have our two closed loop systems. We have one system that is working normally as it should. And so with this one, this is going to be one where you do want to keep an eye out for our oxygenation because we essentially do have that closed loop system with just a little bit of mixing from those openings in the heart. And then we are also going to want to be auscultating for murmurs because again this is one where we actually want for those murmurs to be present, especially if we are providing patient with prostaglandin E, because that is our verification that this medication is working. Another quick thing I want to say about a patent ductus arteriosus, if we are wanting to know if it is open, whether that's abnormal over here with our abnormal patent ductus arteriosus, or if we want to keep it open, there is a vital sign that you can get. It's called a pre and post ductal oxygen saturation. And so basically what that is that you will assess the O2 sat on the right hand of the baby, which is your preductal, and then you will assess it also on either foot of the baby. And so it's expected that the right hand is going to be a higher O2 sat and that the foot would be a little bit lower. But as the patent ductus arteriosus is closing, you will see less of a difference in those O2 sats. And so if you have a patent ductus arteriosus, then you would actually, and you want it to close, you would actually want to see that difference to get smaller. However, if you actually are wanting to keep it open, like we want to keep open for the transposition of great arteries, we would want to make sure that we are consistently seeing that difference because that tells us that it's staying open. Okay, so we're almost there. Now the last one here that we're going to talk about is obstruction of blood flow from the ventricles. So the first one we have here is coarctation of the aorta. And so with this one, there is going to be a narrowing of the aorta that is causing an obstruction. And so with this one, as to be expected, you would have some increased pressure before the obstruction because you're trying to get that blood flip through, but then you would have decreased pressure after the obstruction. And so with our manifestations here, it says that we have increased blood pressure and bounding pulses on the upper extremities, but weaker pulses in the lower extremities. And so with this, when we're picking out what we want to highlight in our cardiac assessment, of course, we are going to be keeping an eye on that blood pressure, and we're also going to be making sure we're palpating pulses. And so one of the things to keep in mind when you're palpating pulses for a newborn is that you're not really going to be able to get that radial pulse, so we palpate pulses for newborns at the brachial artery. And then you would also be able to palpate in the lower extremities, like at the, I'm drawing a blank, posterior tibialis. Okay, it's been a long time, guys. And so moving on here, we are going to talk about aortic stenosis. And so over here we have narrowing of the aortic valve. So this is going to make it more difficult for blood to be pumped from the left side of the heart. And so with this, because we have that narrowing, as I talked about with tricuspid atresia, we are going to have hypertrophy with the ventricle associated, which is our left ventricle. And so here, remember keeping in mind that the more that a ventricle hypertrophies, the less room it has for blood to fill. Because we have our manifestations here of faint pulses and hypotension, once again, we're keeping an eye on our blood pressure and we are palpating those pulses. If you have a continuous pulse ox going, you would be able to keep an eye out for that tachycardia. And finally here we have our pulmonic stenosis. And remember, this is one of the 4 abnormalities coming into play for tetralogy of Fallot. And so with this one, this is going to affect the right side of the heart because we have narrowing at the entrance to the pulmonary artery, which is going to cause our right ventricular hypertrophy, which is our second abnormality in tetralogy of Fallot. And so because we are going to have more difficulty with getting that blood oxygenated to the lungs, that's where our O2 sat is really going to be highlighted. And we're also going to be looking at our heart rate, our respiratory rate, and with both of these, with both types of stenosis, we're going to be looking out for those murmurs, and if it's already diagnosed, then the murmur would be expected, but we would want to be correcting that so that that murmur will subside. yeah, so that was my quick talk through here for my chart. And once again, you guys, you don't have to make it look like mine. Just make it in a way that makes sense for you. If anyone's wondering how I created this chart, I have Windows for my device, so I downloaded an app that's called Click Charts, and it works really well for me. It's pretty basic and user-friendly, so if it works for you, then I think that's great. I am going to have some office hours posted by the time this video becomes available, so if you guys have additional questions, please reach out to Dr. Swartz or me, and I'd be happy to clarify anything that's not so clear from this video. So good luck studying, you guys, and have a good one. Bye.